And so our first session for the afternoon will be moderated by Dr. Adriana de Jesus. Dr. de Jesus is a staff scientist at the Translational Autoinflammatory Diseases section in the Laboratory of Clinical Immunology and Microbiology at NIAID. She is a pediatric rheumatologist by training whose research focuses on monogenic autoinflammatory diseases. So Adriana, I'm going to turn this over to you.
Yeah, thank you so much, Dr. Gray-Woodford. It's my honor to be here today to be moderating this session on the clinical description of the autoinflammatory and neuroimmune conditions. And our first speaker will be Dr. Elizabeth Wells. Dr. Wells is a neurologist and the vice president of the Neuroscience and Behavioral Medicine Center at Children's National Hospital. She's a graduate of Harvard University and the George Washington University School of Medicine and Health Sciences. She holds a master's in health sciences from the NIH Duke Clinical Research Training Program. And Dr. Wells completed her pediatrics and neurology training at Children's National Hospital and has been on staff as a pediatric neurologist within the Brain Tumor Institute and the Division of Neurology for the past 10 years. In addition to her work in neuro-oncology at Children's National, Dr. Wells also developed the multidisciplinary program in pediatric neuroimmunology. She serves on numerous national committees and receives national and international referrals for children with neuroinflammatory disorders. Dr. Wells is a PI for translational research studies and serves in a leadership role for the Clinical and Translational Science Institute and the District of Columbia Intellectual and Developmental Disabilities Research Center. And she has been director of the Inpatient Neurology and the Neuroscience Medical Unit Director since 2015 and was elected president of the medical staff in July 2020. As a vice president, Dr. Wells focuses on the programmatic development of the center, including work on quality and safety of patients, diversity and inclusion as well. So I'm very excited to hear Dr. Elizabeth Wells talking about recognizing and evaluating pediatric neuroinflammatory syndromes.
Thank you so much, Adriana, for the introduction. And hi, everyone. It's great to be here today. So I will be talking about recognizing and evaluating pediatric neuroinflammatory syndromes, as well as the rationale for the CNH NIAID natural history study. And my talk will cover some recent developments, as well as 4 clinical vignettes that will highlight the challenges we are facing and what really motivated our plans for the study. So pediatric neuroimmune conditions commonly develop in previously healthy, typically developing children and present with an acute or subacute presentation of focal neurologic dysfunction or with supportive findings by MRI, lumbar puncture, or other tests. And the presumed mechanism may not be clear, but here are a number of immune mechanisms that are considered for these conditions. They may be immune cell mediated, antibody driven, infection associated, paraneoplastic, genetic, or unknown, and there may be more than one mechanism at play at once. So the past 5 to 10 years have really seen an exponential growth in the research and scholarship of these types of diseases, conditions that are neuroimmune basis. And this has brought improved recognition and fewer delays in diagnosis, with far shorter times to diagnosis. Just 10 years ago, we used to say that the average time for treatment for diagnosis of opsoclonus myoclonus ataxia syndrome, for instance, was 9 months. And now we know that it's presenting much faster, similar for other known disorders. And with that, there's become increased recognition for the unknown disorders as well. There have also been increases in consensus definitions, evaluation algorithms, and increasingly examples of personalized medicine, like we just heard about so nicely in the last talk. And then there are undifferentiated conditions that remain diagnostic challenges. So in terms of diagnostic evaluations, the multiple sclerosis McDonald diagnostic criteria is really the benchmark and probably the most well-known, widely accepted diagnostic algorithm in neurology for neuroimmune conditions. There have been multiple revisions and it's been validated in pediatrics. And what we've seen is that it has helped drive outcome measures for clinical trials. So, for example, the first clinical trial for MS in pediatrics with fingolimod that looked at relapses, reduced rate of new lesions and brain atrophy. And this was really made possible by clearly defined outcomes and definitions. And so criteria have developed for other conditions, and just in the last 2 to 3 years, there have been significant efforts made by international groups collaborating to do this. And we've seen this with pediatric NMO spectrum disease, with autoimmune encephalitis in pediatrics, with opsoclonus myoclonus ataxia syndrome, with inflammatory epilepsies like fires, and with MOG antibody disorder. And then what we're also seeing is how institutions take these diagnostic algorithms and incorporate them into their frontline plans and practices. And this is an example of our internal pathway for encephalitis at Children's National that was initially developed by infectious disease as well as neurology and neurocritical care, and is iterative and updated frequently, most recently with fires management, so that when a patient does present, the frontline team is ready to bring all the necessary tests and evaluations that are needed to get started on the care. One of the more notable diagnostic algorithms that's been very helpful has been that of autoimmune encephalitis in the pediatric patient. And here, the team broke it down between possible autoimmune encephalitis and then went on to say, how do we diagnose antibody negative but probable autoimmune encephalitis? As well as when you have autoantibody positive encephalitis, what to do if there are antibodies only in the CSF versus the serum. And so this consensus was that if the antibodies are present in the CSF, that may be diagnostic, but if they're present in the serum, you also need an additional paraclinical marker. And so with these definitions, we're starting to see the problems that develop when we don't have a biomarker or when we don't have MRI changes associated with active or quiescent disease. And an example here is with the NMDA encephalitis consensus treatment, when to escalate treatment. So the group defined it as failure to improve, which is defined as failure to achieve significant gains in function, or a clinically driven relapse. So return of previous resolved symptoms or appearance of new symptoms associated with change in function. And you'll note here that there's no biomarker or radiographic change during inflammatory flares or the transition from active to quiescent states. And that makes it really challenging for clinicians to decide when to resume treatment and when to stop it. It presents a clinical challenge as well as a barrier to clinical trials. So I'm going to go on to the cases that are going to highlight some of the particular challenges we're seeking to address. So the first patient case is a case of relapse in a 4-year-old female with paraneoplastic opsoclonus myoclonus ataxia syndrome. So she had negative brain MRI and normal CSF findings at diagnosis. She had a neuroblastoma that was fully resected, as is common with this disorder, and underwent 12 months of rituximab, IVIG, and dexamethasone for this condition, which is a movement abnormality associated with cognitive change, speech difficulties, and the potential for long-term intellectual disability if not fully treated. And the diagnostic dilemma came up when she presented at that stage of her treatment with worsening behavior, poor sleep, non-specific eye movement abnormality that was really subtle and mostly just detected occasionally at home, with preserved speech and cognition. So without a really clear marker for return of disease, but with real concern on the part of the parents and the clinicians about missing an inflammatory flare. And this is in the context of data from Wendy Mitchell and others showing that The blue lines up here are more recent treatment versus red squares for older treatment of opsoclonus myoclonus ataxia syndrome in terms of the more aggressive therapy being associated with better IQ outcomes. And so this situation presented a discussion between parents, multiple team members who were really quite split and ultimately decided to redose the rituximab at that point. But then 6 months later, when she was off the rituximab and the same similar scenario happened, but without the movements, a different approach was taken to take a slower IVIG wean, even going as far as Q8 weeks times 2, which many of us feel is, at that point worth stopping. But people have found that this slow wean has been helpful in these situations. And ultimately, she did really well with no relapse and apparently not overly treated for the disease. So the challenge there is identifying active inflammatory states in pediatric neuroimmunology without a biomarker. The MRI being negative or stable at these points, and the lack of a biomarker diagnosis or antibodies. There may be a lack of a biomarker at diagnosis, or there may be antibodies that remain present or elevated even in cured patients. And so you can't use them to guide treatment decisions. However, in pediatrics, the serial lumbar punctures are really not standardized. They are within pediatric cancer surveillance, where we don't might hesitate to do the sedated LPs as part of clinical care, but the utility has really not been established in pediatric neuroimmunology, and we don't know if it's needed. And so with emerging biomarkers and advanced characterization of intrathecal inflammation, there's now a need to further explore and learn from patients who are getting the lumbar punctures. The second case is a patient who had a good long-term outcome after treating neuroinflammation in a 6-year-old boy who had a bone marrow transplant for acute myelogenous leukemia. And so this is a patient that we follow in long-term follow-up clinic. And when he became ill, he was in the BMT unit and had progressive encephalopathy with dysautonomia and dyskinesias. He had diffuse cerebral edema, and the initial thought was that it must be infectious given his risk factors. The edema progressed to actually cause tonsillar herniation, and given everyone's desire to be very aggressive about treating and helping him, he got an extraventricular device and was supported throughout a pretty long coma. His diagnostics revealed a bland CSF, non-diagnostic brain biopsy, negative antibodies, and the working diagnoses were ADAM versus graft versus host disease versus some infection, multiple risk versus benefit discussions. The team, who ultimately decided to treat aggressively from an immune standpoint with high-dose steroids, rituximab, and IVIG. And he took a long time to recover through rehab, but ultimately did beautifully, and now comes to long-term follow-up clinic in 7th grade doing well with just some ADHD and seizures. And when he comes in, we think about, wow, it's really good that we treated him so aggressively. We really weren't sure if that was the right thing to do at the time. And there are no biobank specimens to go back and say, could we learn something new now? And so the second challenge is the need for biorepositories to continue to learn from our rare cases. They help us reevaluate cases with new techniques. They enable us to collect and study rare cases with similar presentations. And we found this at our own biorepository that was started several years ago with the help of Dr. Vanderer, who's going to be speaking today, and now contains 392 specimens from 197 patients and has contributed to multiple projects and publications, and also enabled us to refine our processes for rapid enrollment and sample collection of these at the time that children are presenting. The third case is using advanced diagnostics to treat a 5-year-old boy with FIRES. So FIRES is a febrile infection-related epilepsy syndrome that presents in a child who has a standard febrile illness, develops seizures, that goes on to develop a often catastrophic epilepsy. The seizures lead to more seizures, and there's a cytokine storm that is very hard to control. The patients are treated with all sorts of anti-seizure medications and anesthetics, There have been now some consensus guidelines for how to get started on it, but they haven't been sufficient in the past. And with this patient, we wanted to be very proactive in terms of the diagnostic workup and advanced laboratory studies. And so although the initial CSF was quite bland, we did proceed with weekly cytokines and frequent lumbar punctures as we thought appropriate to guide treatment for his care. His initial neopterin was greater than 300, which is extremely high. And he had multiple cytokine elevations. He did slowly develop HLH criteria, although we felt that some of the criteria were being met due to secondary causes from agents that he was on and other issues related to his inflammation. And so we convened a diagnostic huddle with the Children's National and the NIAID team that's going to be part of our research work, as well as our Children's National HLH team, to really examine the cytokines and try to see if we could learn from the biomarkers that we were trying to find for him. Ultimately, he was started on encephalopathy, which is an anti-interferon gamma agent used for HLH. And we saw a dramatic response in his CXCL9 numbers coming down. And that also coincided with seizure control. Over here, these are his seizure burden from over 135 a day down to ultimately seizure freedom. And now the question is, that he's doing much better. This is the after picture, but he does have this genetic, or rather he does still have some elevations, and we're wondering about the need for ongoing maintenance in the absence of a clear etiology. And so the challenge number 3 is the need for personalized or molecular-based evaluations and treatments for rare neuroinflammatory conditions where current protocols are insufficient. Here's the protocol, here are the anti-seizure medicines, and we needed to do more. And then the 4th case today is a 2-year-old with fever, encephalopathy, and seizures without answers. So this is a child who also presented with seizures after a mild illness. The seizures were fortunately relatively well controlled. However, he was found to have diffuse inflammation, especially of the U fibers, and a encephalopathy that just wouldn't clear. His CSF cytokines were notable for an ILH6 that was quite elevated. His neopterin was in fact elevated, and although that came back about 2 weeks after we started treatment. So sometimes you don't have the data at the time that the patient is quite ill in front of us and we have to make decisions. We sent his cerebral spinal fluid up to the Biorepositories lab at NIH, and the analysis was made with several caveats about the young age due to lack of comparisons. But he did have elevated CD8 T cells and not a lot of markers of innate immune response. He possibly fits the diagnosis of acute leukoencephalopathy with restricted diffusion, but this is a relatively new diagnosis and I think still in that category of undifferentiated. We gave him plasma exchange, IVIG, and siltuximab for the IL-6. He did have improvement in his cerebral spinal fluid and a stable MRI, but his clinical picture is very slowly improving and he remains with encephalopathy and spastic quadriparesis. His genetic workup is pending and will continue to pursue, and his parents continue to ask, why did this happen? And so the challenge here is the need for genetic assessments for undiagnosed neuroinflammatory conditions. And these are really opportunities to understand neuroinflammation at the level of genetics. I show here an example that for 2 of our FIRES patients in our biorepository, they were found by Jamie Fraser, one of our geneticists, to have a missense changes in the same novel genetic locus. And that actually led to a T32 project by Emily Stumpf to look at the cellular localization of the gene in the lymphocytes, the role of TCR signaling and consequences of the variants, and to try to really understand the genetic drivers of neuroinflammation in those patients. And so NIMAP will be a natural history study of pediatric onset neuroimmune conditions with discovery of dysregulated molecular and genetic pathways. It's a joint study by our group as well as Dr. Bielakova and Dr. Golbach-Mansky with investigators at both sites and research teams at both sites. We have a track record of working together to share specimens and enroll our patients in their studies, and we're really excited to make this more of a two-way street and formal collaboration with ease with all the support from this research collaboration. What's important is for some of the studies, the CSF must be processed within an hour of the lumbar puncture, and we've demonstrated feasibility of that already. And so the study will aim to identify shared immune dysregulatory pathways in patients with immune neurologic conditions, to discover potential genetic causes that may be further explored through projects such as that T32 I mentioned, to enhance molecular and clinical assessments during periods of disease activity and quiescence, and to collect longitudinal functional outcomes. And ultimately, we hope this can lead to more effective personalized treatments. The procedures, it will be a 10-year natural history study with careful phenotyping. I'm happy to provide further details for anyone interested. We will be using CSF from clinical LPs and as well as an optional research LP if patients are being sedated already for another procedure, so that we could hopefully get CSF at both times of presumed disease activity and clinical quiescence. And the specimens will be stored for future analysis. Here are some of the techniques that are going to be utilized by the study, or rather approaches: identifying intrathecal inflammation, measuring immune cell-specific biomarkers, investigating mechanisms of innate immunity, the biobanking, which I mentioned, as well as we're very fortunate to add the component of whole genome sequencing through Dr. Holland's centralized sequencing initiative to look for genetic diagnoses or really to explore these variants of unknown significance. And then we'll also bring some novel assessments to pediatrics, including a smartphone neurological examination that's been developed in the Bielakova lab and potentially advanced MRI analysis. And so in conclusion, we are treating neuroinflammatory conditions that we didn't know existed 5 to 10 years ago. I mentioned a few. We're also looking at patients with autoinflammatory conditions who have neurologic effects. We continue to treat patients with unexplained and undifferentiated conditions. And we found that consensus definitions and algorithms are aiding the rapid identification and diagnosis of known conditions, as well as other patients that have inflammation. Negative or stable imaging and lack of biomarker during active disease presents a challenge for clinical decision-making and for the development of clinical trials. And the partnership will bring advanced genetic analysis and immune phenotyping to more patients to better understand and treat pediatric neuroinflammatory disease. I just want to thank our group, everyone who's involved in this, both the neuroinflammatory team, as well as all the frontline members who treat these patients. And thanks for the support, especially to the partnership here. Thank you.